Assalamu alaikum. This is a presentation for medical students by Dr. Mumtaz Ahmed Umar. The main topic is head and neck space infections, and today's topic is retropharyngeal abscess. Retropharyngeal abscess can be acute and chronic. So first I will be describing the acute retropharyngeal abscess. But before going to that, we will see the retropharyngeal space. Retropharyngeal space, it lies behind the pharynx between the buccopharyngeal fascia, which covers the pharyngeal constrictor muscles, and prevertebral fascia. It extends from the base of skull to the bifurcation of the trachea. The space is divided into two lateral compartments, which are known as spaces of Gillette by a fibrous raphe. Each lateral space contains retropharyngeal lymph nodes, which usually disappears at the age of 3 to 4 years. Parapharyngeal space communicates with the retropharyngeal space, so infection of retropharyngeal space can pass down behind the esophagus into the mediastinum and also towards the parapharyngeal space. Etiology: it is commonly seen in children below 3 years. It is the result of separation of retropharyngeal lymph nodes secondary to infection in the adenoids, nasopharynx, or the posterior nasal sinuses or the nasal cavity. In adults, it may result from penetrating injury of the posterior pharyngeal wall or cervical esophagus. Rarely, pus from acute mastoiditis tracks down along the undersurface of petrous bone to present as retropharyngeal abscess. Clinical features: the patient will have fever, then he may have stridor and croupy cough. Dysphagia will be present along with difficulty in breathing, which are the prominent symptoms. Torticollis: the neck becomes stiff and the head is kept extended. Bulge in the posterior pharyngeal wall, usually seen on one side of the midline. So to diagnose retropharyngeal abscess, blood CBC will be done, which will show neutrophilia. Then radiography of the neck, X-ray, soft tissue neck lateral view, it will show a bulge in the soft tissue area of the neck. This is the airway which is compromised here, and it becomes very narrow, giving rise to breathing difficulty. This is the picture of CT scan, which is showing the abscess in the posterior pharyngeal wall in the retropharyngeal area, and the airway, it is narrowed. This is the base of tongue, so it is on the posterior pharyngeal wall, and this all dark area is the abscess. Treatment: so the patient needs to be hospitalized, intravenous fluids started to compact the dehydration, broad spectrum intravenous antibiotics should be started, analgesic and anti-inflammatory drugs including the paracetamol, NSAIDs, and the steroids, they are given. Incision and drainage of the abscess: this is usually done without anesthesia as there is risk of rupture of the abscess during intubation. Child is usually kept supine with head low, mouth open with a gag, and a vertical incision is given in the most fluctuant area of the abscess. Suction should always be available to prevent the aspiration of the pus. However, if it has to be done under general anesthesia, care should be taken that the abscess should not rupture during intubation with aspiration of the pus. So the pharynx is packed, a wide bore needle passed into the abscess mass, and pus aspirated to break the pressure of the abscess and gush of the pus. If the patient presented with breathing difficulty or stridor or airway compromise, then tracheostomy should be done in such cases. So, chronic retropharyngeal abscess or the prevertebral abscess. So, a little anatomy of the prevertebral space. This space, it lies between the vertebral bodies posteriorly and the prevertebral fascia anteriorly. It extends from the base of skull to the coccyx. Infection of this space usually comes from the caries of spine. Abscess of this space produces a midline bulge in contrast to the abscess of retropharyngeal space, which causes unilateral bulge. Etiology: it is of tubercular in nature and results from caries of cervical spine and presents as a mass centrally, while tuberculous infection of the retropharyngeal lymph nodes secondary to tuberculosis of deep cervical nodes can also occur, and it presents on one side of the posterior pharyngeal wall. Clinical features: patient may complain of discomfort in throat. Dysphagia, though present, is not marked. Posterior pharyngeal wall shows a fluctuant swelling centrally or on one side of the midline. Neck may show tuberculous lymph nodes. Diagnosis: so diagnosis is mainly dependent upon the clinical examination with other testing like blood CBC and ESR. ESR will be raised in these cases. X-ray soft tissue neck lateral view may show widening of the prevertebral shadow. X-ray of the cervical spine may show caries of spine. CT scan can also be carried out to confirm the presence of abscess. Monto's test can be done to check for the tuberculosis. Treatment: incision and drainage of the abscess. It can be done through a vertical incision along the anterior border of sternocleidomastoid for low abscess or along its posterior border for high abscess. And full course of anti-tubercular therapy should be given in patients with tuberculous abscess. Thank you.